Thank you for joining me. I'm Dr. Rencus. I'm a neuroradiologist specializing in spine and spine interventional procedures at the New England Baptist Hospital, and I'm also assistant clinical professor of radiology at the Tufts University School of Medicine. Today I'm going to be discussing myelography in the Orthopedic Hospital. Our objectives include discussing the indications for myelography and its appropriate use in spine diagnostic imaging. I'll describe the steps in performing a myelogram, which would include the pre-procedural planning and post-procedural follow-up, and I'll also share with you some common normal and abnormal findings on myelography. I have no disclosures. I'll discuss our approach at the New England Baptist Hospital, which is a little more involved and a little more specifically tailored for patients who've undergone surgical procedures such as fusions, and also review the differences between our approach and other types of myelography performed at community hospitals. Myelography is a relatively tried and true procedure. Among many practitioners in community hospitals, they feel that it may not be required anymore, that it's been supplanted by magnetic resonance imaging, MRI, of the lumbar spine. But in fact, there are several specific scenarios where myelography is important for troubleshooting the cause of lower back pain and radiculopathy, and I'll review the indications for that. This book entitled Myelography had its third edition published in 1975. Not many books since then have had this title. What are some of the common indications for a lumbar myelogram? Adjacent segment disease, adjacent level disease, which occurs in patients who've undergone spine fusion, is one of the typical indications for myelography. Patients who suffer from multi-level spinal stenosis often have one level that is more clinically significant than the others, and myelography is important for differentiating the severity of stenosis at those levels. Of course, there are patients who simply cannot undergo MRI because they've been implanted with a device that is not MRI compatible. And for those patients, myelography is one of the only methods for evaluating the spinal nerves. Patients often who have metal implanted can undergo a CT scan, but extensive metal artifact affects the success in visualizing the nerves, and for those patients, myelography is important. Patients have equivocal findings sometimes on MRI, where the findings do not match up with the clinical picture, and myelography will offer a second view on the underlying cause of the disease. Some patients have other questionable lesions that are possibly CSF collections, and we can evaluate whether and if they communicate with the subarachnoid space through myelography. And most importantly, patients whose disease is brought about by standing. Myelography is one of the few modalities where we can image the lumbar nerves with the patients upright. Most centers do not have upright MRI available to them or upright CT scan. Perhaps in the future that will be available, but for now, if we want to evaluate the patient during their standing position and during their range of motion for evaluation of dynamic instability in the lumbar spine while viewing the nerves, myelography would be our only option. Here's an example of conventional myelography that might be performed at an outside community hospital. Just a brief review, a myelogram is subarachnoid contrast, which outlines the nerves of the cauda equina. On the left, you can see spine hardware from a fusion procedure producing extensive metallic artifact, which obscures the spinal canal and makes for a difficult visualization of potential problems such as discs, intervertebral disc herniations. On the right, you can see with the post-myelogram CT scan, subarachnoid contrast shows the nerves of the cauda equina. Of course, here at the New England Baptist Hospital, we try and go one step further with upright imaging. Upright myelographic images are exquisitely sensitive for lateral recess stenosis. So in this example, you can see a conventional, on the first image on the left, you can see conventional sagittal T2 MRI of the lumbar spine showing multilevel degenerative disc bulging, but no significant stenosis appreciated. The typical myelogram that might be performed at an outside community hospital in the center showing sagittal reconstruction, good subarachnoid contrast, opacification with the myelographic contrast. The image that you're looking at in the center is roughly comparable to a sagittal T2 MR showing degenerative disc bulges but no significant stenosis. So if we stop there, we haven't really added much information above and beyond the MRI, although if this patient had a pacemaker, we've achieved at least an equivalent image. Here at the New England Baptist Hospital, we try and go one step further. On the right, you're looking at an upright image, so the patient is standing and you're looking at the myelographic contrast column, and what you can clearly see is significant lateral recess stenosis at the L4-5 level, which is more pronounced when the patient stands because there may be an anterolisthesis, subluxation at the level when the patient stands, bulging of ligaments, engorgement of veins, buckling of ligaments, all which proves more significant stenosis. And just as importantly, we can see the adjacent levels do not suffer from this stenosis, so this patient has potentially one-level disease that could be treated surgically. What are some of the pre-procedure points that we review before allowing a patient to undergo a myelogram? Well, personally, we review the office notes from the referring physician to understand the patient's surgical history and their chief complaint, and that allows me to tailor the exam specifically for what the referring surgeon, perhaps, or referring neurologist is looking for. Are we troubleshooting a lesion? Is there adjacent level disease? Is this a postoperative patient with spinal claudication? I review the patient's allergy history and make sure they're not allergic to X-ray dye contrast. Iodinated contrast is what we typically use for myelography. Make sure they're not on any blood thinners, including aspirin. Make sure they're not on a seizure, an anti-epileptic. If they have a seizure disorder, they have to continue that medicine up until the point of the myelogram. Oftentimes patients hold all their medicines prior to a procedure, inadvertently holding their anti-epileptics, and this can alter their seizure threshold. We would not perform a myelogram in that case. How we perform the myelogram also differs slightly with what is typically published in the literature and what is done at outside hospitals. Typically, classic lumbar puncture is accessed, the subarachnoid space is classically accessed at the L3-4 level or perhaps the L4-5 level. At this institution, we have vast experience with puncturing at the L5-S1 level if the thecal sac extends down to that level. I personally have done over 1,000 myelograms at the L5-S1 level with very good success, and specifically it produces a essentially painless procedure. The theory that I have behind this is that there are fewer nerves lower down in the thecal sac and therefore fewer nerves to be irritated by the procedure. However, the one caveat is that we do have to have cross-sectional imaging available to us prior to the procedure, either a CT scan or an MRI that the patient's asked to bring with them so that we can review the size of the thecal sac at the L5-S1 level prior to puncture. On the right side, you're seeing a cartoon line sketch of the variations in the normal variations in the shapes of the thecal sac. And if patients have a short thecal sac, which can be normal with very little CSF at L5-S1, then we obviously would not administer the dye at that level. You're looking at an axial T2 correction, an axial T1 weighted image on the left showing the L5-S1 level with a very small thecal sac and a preponderance of epidural fat. This can be a normal appearance. Specifically, what will the patient experience when they undergo a myelogram? They'll be brought into a room similar to this one. This is a conventional fluoroscopic suite, also called a GI suite. They can be placed on the table, prone, with a pillow that is doubled up under their pelvis in order to bow out the lumbar spine, creating a kyphosis of their lumbar spine and increasing the interspinous space, providing an easy access to the spinal canal. We use conventional myelographic kit, which is comes in a tray and can be purchased from any vendors without any significant modification. The needle is a standard spinal needle, shown on the left with a angled cutting bevel, and we use iodinated contrast material without preservative. In this example, I'm showing you IsoView M200, and the M distinguishes it from normal IsoView, which contains a preservative. Preservative-free dye must be used when performing myelography. I'll review a little bit more about the advantages of puncturing at the L5-S1 level. In addition to being nearly painless, because there are fewer nerves of the cauda equina, the more distal you go, there's also fewer nerves if the patient has a spinal stenosis. Spinal stenosis, if it's severe enough, will often cause many of the nerves to be buckled proximal to the lesion, above the lesion of stenosis, and those nerves can be inflamed. We often see them enhance on post-contrast imaging, and if you access the subarachnoid space above the stenosis, the patients will have a painful myelogram. In addition, just as importantly, the dye from subarachnoid injection flows from distal to proximal. So technically, my goal once we administer the dye is to distribute the dye evenly throughout the subarachnoid space for good imaging. That's much more easily done when dye flows from distal to proximal. Another small detail about the approach that makes it for relatively painful procedure for the patient is a paraspinal approach. I avoid the interspinous ligament, which tends to deviate the needle. Paramedian approach, sublaminar, access as shown here, relatively straightforward. I'll talk on a few slides about the risk of spinal headache. This is often one of the most popular questions that patients have prior to the procedure. They read online that this is a painful procedure and that you can get a headache afterward, and they are correct to some degree. Anytime we puncture the thecal sac and enter the subarachnoid space, there is a risk of a spinal headache. In our relatively vast experience here at the New England Baptist Hospital, patients who are over age 40 rarely get spinal headache. Patients who are under age 40 are more likely to get it, and our rate of spinal headache is approximately 1 in 40 patients. A few techniques that we've placed into practice here in order to reduce the risk of spinal headache includes angling the bevel of the needle so that it's longitudinally oriented. So for this standard spinal needle that you're looking at, the hub has a notch, and the notch should point either to the left or to the right when you enter the dura. The reason of that being, I can demonstrate on the next slide. Human dura matter under an electron microscope shows longitudinally directed fibers, similar to Venetian blinds. And if we enter with the cutting needle in a transverse plane, we will cut these fibers, and they'll be slower to heal, and they may allow a small leak, and therefore increase the risk potentially for spinal headache. If we enter the spinal sac with the cutting edge vertically oriented, we will separate the fibers of the dura and be less likely to create a lesion that would be slower to heal. I'll discuss a couple words about the various layers of dura that we traverse when entering the subarachnoid space. The dura consists of an outside dura mater, and there's a potential space between that and an inner arachnoid layer. The cauda equina lives within the subarachnoid space beneath this arachnoid. When we enter the spinal canal, we enter first the epidural space, followed by a puncture of the dura, which typically is felt as a pop in the hands of the operator holding the needle. One needs to advance 1 millimeter beyond that in order to ensure that the arachnoid has also been punctured. If not, there's a potential to create a potential space between the arachnoid and the dura, and the dye will collect in that space. This often is not noticed by the patient, but produces suboptimal image quality. Here's an example of a poorly administered dye pattern. It's a mixed injection of both subarachnoid and subdural dye. There is no epidural contrast here, but you can see that the dye has distended a potential space that otherwise would not exist. If you scan this patient approximately 3 hours later, the subdural space will return to near normal, and the dye will move slowly into the subarachnoid space. Not ideal for image quality. Clinically, not so relevant. The underlying reason for why this may have occurred, the puncture was performed at a level of a laminectomy. Oftentimes the dura is slightly altered from its normal state after surgery. The layers are slightly less adherent to one another, and they can therefore separate out. So after spinal headache, the other concern that patients often have is that they're going to have a painful procedure because everyone has heard something on the internet that would give them nightmares. So my job and our job should be to be able to identify who will be at risk for a painful myelogram and to prepare them for that, but also to be able to reassure those who are not at risk for painful myelograms. So there are a few subtypes of patients. One is those with arachnoiditis. In the center, you're looking at an axial T2 weighted imaging with peripheral displacement of the nerves of the cauda equina. This is in keeping with chronic arachnoiditis. Because the nerves are adherent to the dura, when one enters the dura with the needle, the nerves are all irritated by that for a brief moment. And so entering the subarachnoid space in someone with chronic arachnoiditis can be very painful. But the pain usually lasts a brief moment, and after that they are able to tolerate the remainder of the procedure. The other two examples I have on the left, a sagittal T2 weighted image with a corresponding image on the right of a upright myelogram showing marked spinal stenosis with redundancy and buckling of the nerves. These nerves, if you look on the right side image, almost look like worms. They are thickened and they are certainly inflamed. This patient will probably experience about 15 to 20 minutes of pain after the injection of the dye, which does resolve on its own. Patients should be alerted to the fact that the procedure, approximately 3 or 4 minutes after the dye is injected, the procedure can become very painful. We have nursing standing by, able to administer pain medicine if needed. Not everyone has pain with this spine appearance, but almost certainly all those who do suffer pain have this type of stenosis. And the pain does resolve. Within 10 to 15 minutes, most patients are back to their normal level of pain. Here's an example of a myelogram performed at the L5-S1 level, below the level of a stenosis, below the level of a fusion performed at L4-5 for evaluation of proximal level stenosis at L3-4, the adjacent level. In the first image, you can see a marker needle placed with the tip overlying the intended site of puncture. The second image in the center shows a needle directed along the line of sight of the X-ray beam in a left paramedian, right, patient is prone, right paramedian sublaminar approach. The third image shows the contrast has been hooked up, and the fourth image shows a very nice upright image without any significant stenosis at the proximal level, nicely demonstrated. We take at the New England Baptist Hospital multiple views in order to try and elicit stenosis, perhaps from any dynamic instability. Upright imaging is utilized, flexion extension imaging is utilized, in addition to multiple lateral decubitus and supine imaging, in addition to the standard prone images. Not all myelograms are lumbar myelograms. A cervical technique can be performed with just as much ease. We no longer do cervical punctures for this indication. Almost everyone can undergo a standard lumbar puncture, perhaps 1 or 2 levels higher than typically performed for the lumbar spine. And with the gravity tilt table, the dye flows very easily to the cervical spine, and we can perform very nice cervical myelography with a slightly modified technique as shown here. A CT scan is performed in almost every patient following the procedure. This is a recumbent image. CT scan is recumbent. Patients are supine, and Reconstructed images with modern CT scans show imaging, as I've shown you before earlier, essentially equivalent to MRI, with actually better spatial resolution and some say slightly better evaluation of any osseous underlying abnormalities. Technologists are instructed to image well above and below any hardware in order to not miss any adjacent level diseases. I'd like to share a couple more examples with you so you can appreciate the value of myelography. Here we're seeing a relatively mild to moderate degree of stenosis at the L3-4 level, shown purely on supine imaging on both sagittal axial MRI on the left and sagittal and axial CT myelography on the right. The upright myelogram here's another example showing you the difference between the upright imaging and the prone imaging. On the left, you have a prone myelogram showing mild thickening of the nerve roots, slight redundancy of the nerve roots, but essentially no myelographic block. Contrast can pass across this area. When the patient stands, there's a clear myelographic block with the contrast above the level of stenosis unable to pass the stenotic L3-4 level. Certainly the sine qua non of significant stenosis. Here's an example of flexion and extension imaging. You can see how when the patient extends their back, the stenosis at the L3-4 level becomes more severe. This is a well-known feature of spinal stenosis. A couple more examples of myelographic findings. Here we're seeing adjacent level disease at the L3-4 level where the patient is instrumented with pedicle screws at L4 and L5. The proximal the first adjacent level at L3-4 has a large disc herniation. The surgeon wanted to evaluate how significant this disc herniation is with respect to flow of CSF across the cauda equina. Top right image and the bottom right image shows you a complete myelographic block when the patient stands at this level. Not everything that we evaluate on myelogram is related to spine surgery. Some patients have other indications. In this case, the patient did undergo a small laminectomy, but subsequent suspected dural leak. In this case, the findings on MRI were sufficient that a myelogram is actually not needed. You can clearly see in the large T2 bright collection, which not only appears to communicate with the subarachnoid space, but demonstrates on the right, you can see in the upper and lower axial imaging, demonstrates flow signal in keeping with a rather petulant communication. So not everything requires a myelogram. Some cases are quite peculiar and unusual, and myelography is employed in order to troubleshoot the underlying cause or etiology. Here you're looking at a T2 bright lesion within the right pedicle of L5. Was unclear whether it has communication with the subarachnoid space. Certainly an unusual lesion that we don't see every day, and a myelogram was performed which could very immediately and clearly demonstrate communication. On the left you're seeing during the contrast administration, so certainly only a few seconds after the contrast is being injected, there is prompt filling of this structure, this intraosseous pseudomeningocele. On the right-sided axial CT reconstructed image, you can see a fluid level of contrast within this pseudomeningocele. So in summary, I hope you agree with me that myelography with some practice is an easy procedure, usually painless, safe, and very diagnostic. Thank you very much.